I had a miscarriage too, so just keep on moving. You all right, you're going to have another one.
Yep.
But I still lost a child, and I want to talk about that with somebody who's not afraid to be vulnerable about what happened with them. So let's crash that stigma. We're not strong Black women. We break, we cry, we get upset. And issues that we don't talk about are the things that fester and cause us medical and physical harm.
And to your point, in terms of maternal mental health, right, we're less likely to be screened for conditions. And a lot of the research shows that if providers don't perceive that we're having an issue, they don't ask us about the issue. So the strong Black woman syndrome, okay, I see you over there. Well, pass the plate. But like, we're not getting screened, period. And women will come to me, they start me on therapy for Black girls, and we're having conversations, and I'm like, oh, you have some significant major depression and anxiety. And it's like, oh, I had a pregnancy loss, second trimester. This is, like, I'm pregnant again. Like, I'm scared every day. And I'm like, have you told your doctor? Well, like, they see in my chart. And I'm like, have you talked about it? Like mentally you're holding a lot. And it's like, well, no, they haven't asked me. I'm like, you don't get an EPDS, like nobody ever asked you. But the research shows that, one, we're not getting screened, and they're only screening people who they perceive to have issues. And so you never know what just because I make the load look light doesn't mean I don't have a ton of pressure in my bag. So that's why we have to push for screening, like universal screening.
Exactly.
Ooh,
you are your own best advocate.
Right?
I mean, I was like
amen to your sermon, because that's the whole word, right? I don't know if it was teaching or preaching, but I'm gonna go and move in the spirit, right?
Okay. Because I need my tambourine. This is my tambourine here.
Really, because you're hitting on so many points, right? When we talk about women or birthing folks that go through the process of pregnancy, however you achieve your pregnancy, right? You achieve a pregnancy, and we're talking miscarriage is 1 out of 4. We're not even talking about stillbirth. Right? Or a child lost following the birth of a child, right? So we're not talking about any of those stats, but just miscarriage is 1 out of 4. Consider the others. If perception is what guides whether I screen you or not, if I don't deem your miscarriage as you being a mother, why would I screen you for a postpartum?
Okay. Wow.
Right? If I don't perceive the experience you had to categorize you as a mom. So I think we have to put, the reason I pulled up my chair and flipped that table.
Okay.
Is because we have to shatter some of these stigmas, right?
Yes.
We can't stigmatize what motherhood is. At the end of the day, if someone is postpartum, that means they've in some way engaged the pregnancy and birthing process. Whether it was a DNC, whether it was a stillbirth, whether it was a very traumatic miscarriage that was unexpected in the first, second, or third, we have to consider that. Whether it is, you had a great birth and you have a healthy, happy baby, you should still be screening for these diagnoses and conditions. And we have to, I'm pulling up my chair so we can talk to our medical colleagues. We all have
be a part 2 and 3 and 4 and 5. I love them. But if we having a social work powwow about pulling up our chair, you know what I thought about today? I was meditating about this, and I thought about, in my experience, again, in a large local hospital system and with the Department of Defense, I feel like social workers are often in this space, we're often treated like ornaments on the Christmas tree. But we're really the branches, like the root and the I don't know, the middle part, that's the birthing person. But the trunk, thank you. But we're the branches, like we're not necessarily catching a baby. We're not like a one issue kind of thing. Like we're involved with people from the beginning to the end, from therapy to case management to referrals and resources, and even in the interdisciplinary perspective when we're talking to the medical providers, because let's be real about the soft skills. You might know how to do a cesarean, but do you know how to talk to someone who had to have an emergency C-section that was not not part of her birth plan,
That part.
who is healing from a major surgery, just had a baby. You know what I'm saying? So like us having these conversations, and I just, I pull up like this everywhere, but I'm just saying, like, having these conversations where we're not like the parsley that you sprinkle on the Alfredo before you serve it. You know what I'm saying? Like, it ain't no Alfredo without social workers.
You can't have look. Think
It
about
ain't no
it this
chicken
way.
without social workers. What are
You
you
can't
talking
have a sauce
about?
without the seasoning, and we the seasoning on that thing. So stop just thinking it's me as dressing oregano, okay? Like, we are literally what gives you flavor and purpose. Like, we have to lean into that.
And we have to also make sure that our role is clearly defined. I am
That's
not a
what.
counselor when I'm a medical social worker. I am a clinician, and I contribute more to that patient's medical care than the nurse who gave her shot, than the doctor who ordered her prescription, because I'm with her from beginning to the end, asking about her mood, her life conditions, her environmental factors, her financial. And whatever you need to treat her, your information probably came from one of the assessments
Say
that I
that part
did.
again. Say that part
So we
again.
need to demand that those in medical social work are treated just the way you would treat an RN or a radiological technician who you pay all that money to.
Okay.
What they contribute is not as vital as what I can contribute, because I get to the heart of the patient.
Mm-hmm.
You only get 15 minutes.
Mm-hmm. Okay, that part. And to your point, most of on the mental health part, we know that licensed clinical social workers, we hold the most. We're the, how do I say this? There are more LCSWs than there are psychiatrists, psychologists, and psych nurse practitioners combined. So we're the people doing the work, even though it's not a whole lot of us. We're not the bulk of it, but it is the profession that is doing most of the mental health treatment. So when you reframe it that way, we should not be an addendum to a plan or a maternal health project. Like,
We
we
should
have
be
to be at
gatekeepers.
the very core all the time, because to your point, we're the ones intercepting or assessing the social determinants of health, like the whole person and environment, right? Human behavior and social environment. Like, we know those things, and that's what you don't know, and that's what's pertinent. Like, that's what's going to change your outcomes.
And I think like we are literally moving right into what I was going to ask about next, which is kind of like, what are those barriers for us as social workers being more involved in maternal health care? And I know, Rochelle, you were talking about one piece being that there's ambiguity about what our roles are. And also there's this idea that we can kind of be like put into those difficult situations. We can just be plugged in when someone needs to address issues around grief and loss potentially. It's like, oh yeah, you can talk to the social worker. It's kind of like, oh, mental health is your thing. We don't have to worry about that as much over here. We'll stay with the physical health if you do the mental health. And then also in the realm of research, we are left out completely in many instances, despite the fact that, and I'm going to keep it real here, social determinants of health is not new to us. That is a new concept to many folks in the health fields, but social workers have been talking about person and environment since the beginning of our profession. We have thought about and worked on issues within one's physical and social environment since we became a profession, since we were working in settlement houses, since we were working within communities. And yet we are left, even from that research, even within the coining of that term, you will never see that this term has been influenced or have been derived from frameworks that were developed by social workers or anyone in a social science field. And so I have been oftentimes the only social scientist, and having to bring that perspective and having to question, how are we even characterizing Black patients? Because that characterization and how they're being perceived, it contributes to negative outcomes in practice,
Absolutely.
but also can contribute to negative outcomes in research.
Right.
And so, like, we're oftentimes having to ask those hard questions, having to pause people, like, hold up, that don't sound right. That's not what we're going to do. Person-centered as well as patient-centered approaches are new concepts. We have been about people for the longest. We literally have said in our code of ethics the dignity and worth of the person. But yet we are left out, and it's just like, oh, this is a hot topic. This is where the funding is. This is where, you know, the grants are asking for us. Oh, we can add you as a, you know, consultant potentially, or maybe you can just, you know, provide your insight for free. And I said,
okay, now that part,
ask up.
okay.
You better back that ask up. No.
Okay. Oh, I love that. Back that ask up. I had to use that because my vernacular is a little different.
That was
I like that. I like that. See, that's why you have that PhD. And I like that. I love that we have people like you who are like holding, you know, bringing truth and illumination to this space, because we have been here. And it's, I think about like Kim Kardashian, like creating cornrows, you know, like we've been about this work. And so I'm glad that, you know, Black researchers are out there. But even from what I know in this space is Black researchers don't always even get the money on Black topics. So, you know, I mean, there's just a lot. And that's why I said, you know, I think that there are a lot of well-intentioned initiatives, but until you involve us from the beginning, throughout, at the end, people with lived experiences, until you do that, because we didn't even go into like, you know, mistrust of medical systems and how they have treated us, and, you know, Black birthing issues from, can we go back to chattel slavery for a minute? I mean, because like when we're talking about the context, and I'm always telling people, you know, context informs the content. So, you know, like I love the fact that this year it's like our bodies still belong to us, you know, like they have always belonged to us, but I mean, they have been like rented out, you know, like we literally have been sold. And so sort of like reclaiming for Black birthing people, but also for our profession of like really, and I think to your point with your question, I think one of the challenges is nuanced in the sense of people don't know everything that we can do, and so they assume things that we can do. And then on the flip side, I think that sometimes when people have an appreciation for what we can do, they want us to do everything. I'm doing the CPS cases and the crisis response and the PMED referrals, and it's just like I can do a lot. Social workers can do a lot, but you know, let's define what my role looks like in this space. And I think that also gets blurred because not everyone who works as a social worker will identify as a social worker. Most of my OBGYN friends will identify as an OBGYN. You know, some kind of way, you know, they're a medical doctor specializing in women's health. But I know social workers who are researchers, program evaluators, executive directors, and we're all in this space. And we may have social, you know, groups where we identify, we know that we're social workers, but sometimes it doesn't, what we can do, the spectrum doesn't always get, we don't always get the credit for it because people don't know that, oh yes, that researcher is a social worker, or that program director, that grants manager, that's a social worker. You know, that psychotherapist is, we got to use cute words because people
right.
So that psychoanalyst, that psychotherapist, that's a social worker. So I think also, you know, and that's why I try to use it as often as I can. Like I'm all these things, but at first I'm a clinical social worker. Howard trained, Howard prepared clinical social worker. And so people will know, okay, I'm doing all these things, but I'm a social worker.
Exactly.
That goes to the point where the NASW needs to reclassify or sort of delineate the different roles in social work. Because if you Google for a job, which I'm currently doing, and I just put in social worker, I would be at a school, at a private therapy office, or at a criminal justice program first. But I have to specifically type in medical social worker for me to find the jobs. And then I have to wean out case managers from medical social worker. Because please know, case management is not the same. They might be social workers doing case management, but it's not the same as a social worker. So we need the organization that defines our role to classify each role, and therefore we can petition insurance companies and major local healthcare organizations to pay us accordingly because we're fully licensed. We have an MPI number as providers. We have more training and skill in many different areas compared to nurses, comparable to nurses. So our licensing and our governing agency needs to advocate for us to be, hey, this person, if they're an LCSW and they have medical experience, this is the skill level, the expectation and standards that they're governed by. And therefore you must pay them according to that skill.
I want to
Hey,
add to that because I really think it might be an importance attached to us as social workers, just accepting that the one thing that we do and we do really well is we fill gaps. Since our inception, we
yeah,
identify the gaps, we attempt to rectify the gaps in a interdisciplinary way, and then if we don't, we take it as our own. That's why we have so many different niches and populations and programs in social work, because
right.
there are so many different gaps and things that need support and filling. And even when we talk about maternal mental health or medical social work, that's just one leg
Yep.
of so many different opportunities that we can step into as a social worker. So I think, kind of speaking to both of your points, it's important to maintain the integrity of our profession. Acknowledge yourself as a social worker when you step into rooms, regardless of the greatness, that we're like bringing.
Yep.
Acknowledge yourself as a social worker so they know where this foundation comes from, right?
Ooh,
Where we're considering things from, and why we're able to wrap things all together. There's so many different nuances to what we do that we can't sit here and try to box our profession in. So I think
Yep.
one of the biggest things we can do is acknowledge that our profession is big and
Yeah.
our roles are expansive because we do such varying work. But we all do work regardless as a social worker.
Right.
yeah.
And we also need more social workers in the political arena to advocate for us and to lift our voices up because we're the solution to most of the problems they're facing in politics, but we're not heard. So for you social workers interested in the legal, please go, please do it, please get involved in politics.
Yeah, I think another piece of this, and I love me a good policy, especially when it's going to be for the betterment of my folks.
Okay.
Um, but I also wonder amongst us as social workers, what are we doing to hinder that? Like, are we seeking this professional validation and saying, we just want to be a part of the club, and then because of that, we're sacrificing our position and our power in order to get a seat at the table? Like, are we just saying, just, because we do the hard work of filling gaps, we also do the hard work of connecting the dots, right? And so is it that we're seen kind of as helpful in other folks' work, or are we seen as an entity that stands in itself as important work? And how are we as professionals contributing to either of those arguments?
Mm. I think, oh, and I'm trying to figure out how to dance around that, but keep it real at the same time, you know?
Okay.
Um, because, I mean, really, like, what we don't want to do in social work, and I guess this is just me thinking as a career consultant with social workers, what we don't want to do is like, oh, you're at this tier because you have this degree. You're at
Right.
this tier because you have this license or certification, right?
Right.
But we also want to create a baseline of what is it to be a social worker. And the baseline, since last time I checked, CSWE, NASW, and everybody else agreed, having an accredited degree from an MSW or BSW program is what makes you a social worker. Everything is in addition to that is what specializes you in a certain realm to practice. It doesn't make you any more or less than any other social worker out there. And I think sometimes we're so busy trying to appease externally that we fall into the trap of, oh, I got an LC, oh, I got a doctorate, oh, I got this certification, oh, you know what I'm saying? And people forget, yo, we all social workers trying to make this world a better place. Even though I might have the credentials, but my credentials are based with the point of supporting, engaging someone else, honestly. Besides getting my coin, we're talking about serving others. That's the point.
Okay, now we really pulling up. Now you know them credentials is gonna be the difference between the coins you get between a penny and a dime and a quarter.
I
So,
feel that. I
but
feel that,
but
right?
I do feel you in the sense of, and I think that this society, I think that capitalism feeds into that, right?
Oh
Like, because
yeah.
we all got the alphabet soup, but I think I don't feel like I'm better than anyone else, but I do think
Not really.
working in a medical system, the credentials do
Mhm.
get you to the table, and the credentials do, I think it's the credentials, but also my integrity and me holding
Yes.
true to the social work values, because I've been in places for DOD, for instance, where I started, and I worked in an interdisciplinary team, which, and it wasn't a maternal health team, but it was a really great team where like people with specialized needs would come in. Instead of having 20 appointments for a month, you come in a full day and we rotate. You see all the specialists every day. And so whenever I would go in, I would get interrupted by this department, by this department. Are you done? Are you done? I'm like, I'm over here doing a suicide assessment. Don't come in the room when I'm talking to people. Do I come in when you looking at x-rays? And so, but it took time, and it took me just saying, because I guess the previous social workers just kind of worked around it. Like, I'm talking to them about a divorce. They're about the PCS. They getting a divorce. The kids staying here. You trying to plan the surgery. You need me to figure out what's going on right now. And so I think that it's like, it's not necessarily the credentials, but I do think in some spaces other people do look at that in terms of, oh, who is this? And not that you need them, because I think, on that same spectrum, that's why and how they also disregard lived experiences, right? Because it's like, oh, who are you? And it's like, hell, I'm me.
Exactly.
I see that with my full-time job. I was just telling my mom that I got a prescription from CVS. I go there, just not like I'm looking right now, but I go there, like a dermite, and I get regular treatment. I walked in with my NFL gear one day, and it's like, oh, Miss Alford. Oh, Miss Alford. You know what I'm saying? And it's like, people do respond to that. We shouldn't, but people do. And so it's like, it's interesting. But all of that to say, I think it's a lot of this, like, and the point of this conversation is that there's so many layers, and it's so nuanced. And I think that, to the question that you asked, is sort of like, that's where I was going back earlier about, like, not being the ornament on the Christmas tree. I think as long as we know that we're serving purpose, I feel like as my career has evolved, because I used to be real mad, like even working in child welfare, like I'm the one seeing the client, I'm the one with the child all the time, with the mom. Like if I say I assess, it's not my personal opinion, my clinical assessment is blah, blah, blah. Why don't I get to talk at court? Why is it the doctors and the lawyers making? And I used to get really pissed until I realized, like, that's my superpower. To your point early in this conversation, most assessments are in some way, shape, or form influenced by the work that we're doing. And so now, instead of asking or insisting, I just command it. Like, I'm going to be persistent. This is the assessment. These are my concerns that I want to raise, that Miss Johnson spoke of, and how are we addressing those? Yeah, you told her about this, but did you explain that? Or did you tell her about the options even within this medical system? So that's, I don't know. I mean, do we play nice, and like, do we keep asking for a seat at the table, or are we flipping them over? And I think it's day to day, because some of them I flip over and I got to put them back, but then I sit over. I think it's a dance. You know what I'm saying? But
it is.
You know what? Are we just flipping over the tables? Are we just pulling up our seat, or are we inviting others?
yeah,
And I think that's one of the biggest things, because what I may not see, another social worker may be a crazy specialist in, and they see it. So I love what you said about just, both of you guys talked about our superpower, and kind of, not necessarily being at the forefront, but at the same time being able to step back and observe. Because when we can see these gaps, that means we get to bring proof to, hey, did you notice this, that, and the third? And this is the second and third order effects of this action. So how do we rectify that? Oh, I know you didn't peep it because you was over there doing it. I'm here observing, right? So how do we correct this issue now,
Yeah.
Right. But we have to be willing to kind of position ourselves to ask those hard questions, which The term moral courage is something that we hear in our field often, and many folks are still working towards that. And I think part of it also means that we have to acknowledge what history we're bringing to the table with us, because we're not clean. Our hands are not clean. We have played some roles in horrendous parts of history in terms of maternal health care. And we have to come with that acknowledgement. And that's not even just maternal health care. We also have to talk about child welfare. We also have to talk about in schools. We have to talk about all of the different realms in which we work and interact with families, children, parents, caregivers overall. But do we feel empowered to ask those hard questions while also acknowledging that history? Are we equipped to do that? Or are we equipped to get along to get along?
I think we are more than equipped and capable of asking the hard questions while also maintaining a space of accountability. Because that blame and responsibility thing, right? But we were accountable and be accountable for history. I think when we don't address history, especially when we talk about things like gynecology or like reproductive health, when we don't address history, we're doomed to walk back into it like we ain't been before, right? We talk about Black women, we have to consider women of color have a very volatile relationship when we talk about the topic, because the father of gynecology, right? And if you don't know, please look it up, right? But it's like we have to be honest about history and consider where we are presently and where we want to go. Do we want to walk back into that same thing by, it wasn't on me though. It wasn't my burden. We can be accountable and ask the hard questions, push forward.
And the onus is on each of us to break the stigma associated with social workers. Like when you walk into a room and you say, "Hi, I'm the social worker," and they face, no, I'm here to help. I'm here to support. Whatever you might think of a social worker, that's not the role that I'm playing here. So we also have to break that stigma of, no, I'm not here to snatch your baby. No, I'm not here to kick your child out of school. We have to break that stereotype of people attaching social work with something negative. We need to speak up and say, no, my role does this and my role does that. And I'm more helpful and supportive than I'm more about tearing apart or breaking down.
I love that. And to your point of how we also break this cycle of perpetuating traumas and atrocities to the community, I feel like one way I did that as a military social worker is just reminding people we're all mandated reporters. I feel like so much of maternal mental health when it comes to Black women, especially Black birthing people, is the fear of like, okay, if I go and tell these people I'm over here having these suicidal thoughts, you might take my baby. Like if I go and tell you that I really sometimes don't know if I want to be here, you may say I'm an unfit mom. And so I think there is a lot of work being done so that people understand more what perinatal mood and anxiety disorders are. And when I say people, I mean professionals and medical providers, but also, I would push back if I didn't ethically assess that there was a CPS need based off of the jurisdiction that I worked in. I would just kindly remind my colleagues that we are all considered mandated reporters. The social worker is not only, and I would also share, hey, this is my concern. This is where I think that, there may be a disconnect or this is what I think may be going on here. So I would share that. But, and not that I'm saying not to make a safety assessment or referral when needed, but I would just also remind people, because the truth of the matter is, providers are people too. We all have our own biases and, all that kind of stuff. And it comes up in the work that we do. So I would always kind of push back, especially having been a child welfare social worker. So I would just be like, I'm not, and I had to get to a point, because we keeping it real in this conversation. Because I do work for a paycheck. I am a first generation college student, and I am single and not married. If anybody's out there, but I'm just saying, I don't have a helpmate or a trust fund. I'm out here on a wing and a prayer trying to do some good work. So I mean, but when we talk about like moral courage and ethical dilemmas, like it's really real. Like
Yes.
what can you be bought for? And for me, I really had to like meditate, EAP, the same stuff I'm telling my clients because it's like yeah, and I mean, let's not forget, like in military, we may have rank involved. We might have a whole lot of different dynamics. I mean, in whatever environment you work at, you have hierarchies and you have situations, and it's like, am I really willing to stand on business about this? And what I had to start doing, and I'm grateful for my experience in child welfare because it really tested me as an individual. Like you out here, these theories and you can quote this and that, but like, what are you doing in these situations? And when I had to say, like, okay, no, like when I had to start writing court reports where the agency made a recommendation and this social worker, because I had a different opinion, I knew that like those records still stand 10 years later. Whatever I wrote still affects these people's lives every day. And so I have to practice in a way that I can sleep at night, that is ethical, but also like, yeah, like I'm not going to be used in that way. And I think that we all have to get to that place and whatever feels comfortable for us. But, like, and however that looks for you, but I have to get comfortable. Like, yeah, no, like if you want to make a report because like, whatever you want to make the report on, if it wasn't something that I assessed and my, management or whomever I reported to said that we are in agreement. And I mean, and sometimes it was having to push back on that too. Like, I know that like this is a clinic, this is a director. I know this is a colonel and his family, a colonel's daughter. And I'm like, yeah. And in the same flip side, there were times where I made a report when I was advised that we probably shouldn't and give referrals and information. And I put my note in the record, that this was my assessment and this is why. And I had to be okay with that.
I mean, oh my God, you hit so many different things. And I think I'm just going to follow up by saying, not just stand on principle, and stand on ethics.
Yes.
And the funny thing about ethics, because I love talking about them, that's what happens when you teach ethics in college. But anyway, the funny thing about ethics is it is actually an ethical mandate that social workers have a vested interest, involvement, and work ethic towards the larger society.
Yep.
Right? When we talk about marginalized populations, right? 11% of US couples experience infertility. Is that now not a marginalized population? 1 out of 4 women experience miscarriage. Is that now not a marginalized population? You have to be willing to be uncomfortable and ask the questions. Provide a space for growth. Growth does not happen when we all cushy, comfortable, and sitting real pretty. Growth happens when we are uncomfortable than a mug and we have something that we have to address. So be willing to be the professional troublemaker. Ask the hard questions. Challenge the status quo. Because last time I checked, once upon a time, there was quite a few things that whether within our profession or just in our society at large, they were legal, they were allowed, but they weren't cool. Right? And somebody had to challenge it. As social workers, we are conduits of change. That means we have to be willing to be uncomfortable. So, social worker, be uncomfortable. That's where the change is going to happen. That's where the growth is going to happen. It may not happen with you, but it may start because of you.
Exactly. I don't know how many times we are kind of in the role of having to acknowledge that we are not going to reap the benefits of our hard work. And we don't, most of us do not go into it thinking, oh, I'm doing this for myself. Like it's impossible to do that. But we're always having to think long term, how can this change systems? How can this change the experiences of people who come after me? Which brings me to my last part. We need to do some reimagining, right? Yeah. Like what can this look like? What can it look like for social workers to be at the table, maybe even in the cushier one at the head of the table? What could it look like? What would it look like, and how would outcomes change? Let's really dream about this.
I think about my own personal experience, and believe it or not, the first question I asked was, where's my social worker? I'm a social worker in active need of a social worker.
Yes.
If I'm going through this as an informed professional,
Yes.
how is
Exactly.
someone going through this and they don't know?
Mm-hmm.
Right? Where is my social worker? So allowing yourself to imagine yourself in the room. If the position don't exist, make it.
Mm-hmm. Mm-hmm.
If you believe there's a gap, identify it, because you may be able to fill it in a non-traditional way. We make
Exactly.
roles in social work every day. Why aren't we at these fertility clinics where people are receiving reproductive and fertility treatment? Why aren't we, being called when it comes to specific medical surgeries? Why aren't we encouraging the education about reproductive health care challenge diagnosis like ED or PCOS or endometriosis? Where are we? And if we were there, what would it look like? How
Mhm.
would things change? Right?
Mm-hmm.
And then run towards it.
Mm-hmm.
Yeah.
And you
Yeah.
make a great point because we are the ones who fill the gap, who identify and make the dots to connect the gap. So when people ask me, well, you have your master's in healthcare administration, why do you need a master's in social work? Because you weren't listening to me when I came at you as an administrator. So let me come at you as a way with certifications, license, skills, and training that backs up what I say. And you have to listen to me because I want to advocate for the person, not for the billing cycle or the fee for service. I want to address the problem, the underlying condition of the person.
Mm-hmm.
And so, as an administrator, you're not going to listen to me on that. But as a social worker, you're going to say, well, yeah, she knows what she's talking about. Plus 20 years of medical experience. I think we better listen to Rochelle. So you have to make your own way because I could have stopped at my age. I definitely could have stopped and just worked at MHA. But no, I see gaps and I see problems that my voice with those alphabets behind my name will make you listen. And it's not for me to be validated. It's so that not another 1,406 women die a year.
Mm.
Mm. Mm. Mm. Mm.
Mm. Mm. Mm. Mm. Mm.
And Rochelle, you speak. I had to let that breathe for a second.
Okay, yeah, that's what yes.
Let it breathe for a second.
Okay, okay, yes.
So no one suffers in silence.
Yes, yes.
She hidden.
Mm-hmm.
Because I share my story. That's oftentimes how I get my foot in the door because of my own personal experience, my own personal trauma of being diagnosed with peripartum cardiomyopathy or pregnancy-related heart failure. It runs off my tongue so easily now for some reason. But then I say, oh, I'm not just a patient. I'm a patient advocate. I'm a researcher. I'm advocating for policy change. I'm also involved in community organizations. Shout out to Equity Before Birth, who's having their dance party tomorrow, 4 to 7 p.m. at the Museum of Life and Science. Sorry, had to put up that real quick. But I'm bringing all of those with my identity, my overarching identity as a Black woman to that table. And so I'm going to ask, have you considered, when you're asking people for their stories, are you considering how you are compensating them for that? Are you considering how you are protecting them from that? Are you considering how you are creating a space where that isn't just re-triggering trauma? Like, those are the questions that they don't come up. They don't come up, but that's my social work skills. That's what I do.
Yeah.
We don't ever look at the person as just one thing, as one dimensional. We can't, because no one's one dimensional. No one.
Exactly.
We all come with our different stories, our own experiences, for the good, for the bad, and we're coming with a way of looking at the world that can be valuable, especially when we're thinking about changing systems that aren't working.
Yes.
The fact that we spend so much on healthcare but have such horrendous outcomes signifies that we need to do a lot different. A lot. And so how dare we expect the same thing to lead to different outcomes? That's the identification or the definition of insanity. We have to do things differently in order to get different results, which means that those who have been left from the table, left outside the room, or not offered a menu at the table, we need to change all of that up.
Yes.
Love it.
Yes.
And it starts with each and every woman on this call who pulled up a seat at the table. Your doctor puts their pants on one leg at a time. They pay mortgage, they pay light bills. They probably had a fight with their child on the way into work. Do not take everything they say as absolute. You know your body, you know yourself the best. Speak up. Advocate for yourself. Know how you feel and don't just brush it off because, oh, well, the doctor said don't worry about it. No, I'm worried about it and it keeps bothering me, so I'm going to worry you about it. Advocate for yourself. Speak up for yourself. Know that they're humans, not demigods. They go through the same things we do, and unless you make your voice heard, they're not going to treat you appropriately. So be your own best patient advocate.
Yeah, but I also say sometimes it's not only what you're saying, but also what you ask for, right? So if you feel that you are not getting that treatment that you need, I want you to document, please. Please put that in my record that I have asked for this particular test because I have these specific symptoms. And if you can, because I'm a social worker, and if it didn't, if it's not documented, it didn't happen.
It didn't happen.
Amen.
Can you document so I can know, so I can see it in my electronic health record that I did ask for this and you refused?
Exactly.
But that takes that's something I'm comfortable with. I'm not sure if my mom would have been comfortable asking her provider, hey, can you document this?
Yeah.
Like, that's something that I have been empowered to do. But now it is about how do I help others become empowered to do the exact same thing?
Yes.
Can I help strengthen? How can I provide backing to them so that they feel empowered to do that? Because these systems have torn folks down.
They have. Oh, yeah.
People have been considered not compliant, difficult patients. They have been told you're just making things up, you're exaggerating, you're just trying to get medications, like all of these things. And there is a power difference within that provider-patient relationship. So what we have to do with our insights, with our training, with our passion for people, we need to interrupt that from happening moving forward.
Yeah,
that's my thought.
I love that. And that part of that interrupting is like you said, because I think like advocacy is something like, we need to advocate for ourselves, but like, what does that look like? And asking for people to document, asking for, and I always say this because it comes up in my therapy sessions, but ask someone, what else could this be? What else could this mean? Because sometimes like the documentation is good. God forbid something bad happens, it's in your record. But what we don't want is a bad thing to happen. Like if I say I've been not feeling well, or this pain in my side for a long time, or headache since I gave birth, or whatever it is, and they say, oh, that's normal. Okay, and what else could this be? How have you ruled out, right? This is medically called a differential diagnosis. How have you ruled out that it's not something else? How have you ruled that out? And so just kind of continuing to unpack that. I think that like we have to keep on having these kinds of conversations. I mean, when we think about how we can continue to like evolve this space, I was just thinking about the fact that, we know that perinatal mood and anxiety disorders are like, one of the leading complications of childbirth. But from a sexual health perspective, I'm talking to people about broken coochies, like we talking and we pulling up to the table. I think it gets separated. And it's so ironic to me how sexual health and sexual well-being gets separated from maternal health when they go hand in hand. But it's like, if we're thinking about PMADs and, like we're thinking about like, okay, how did like my coochie broken, my body is broken, my relationship is broken. I don't know if I can be the mom and partner that I need to be. We're thinking about all of these different things. And so I think like broken coochies get left out of the conversation. And we have to have conversations. If social workers were leading this space, or if we had more of a role, I would expand it to maternal health. Is not just a pregnant woman, it's not
Right.
just, childbirth, it's not just mental health related to the pregnancy experience. It's all the things in that intersectional perspective of like what it means to be a black woman in America, what it means to be a black woman. And I think like that's what makes it so nuanced. I think the status, like, we're twice as likely to experience postpartum depression, and we're not as likely to get screened. We're, experiencing suicidal ideation. And a lot of that is not just about the pregnancy and how it went. I'm talking people
Mhm.
about like the dishes. And you would really
Yes.
think it's easy. It's so crazy how things get separated. And it's like, well, this ain't got nothing to do with that. And it's like it has everything to do with how I see myself in this world and how I'm functioning, and how maybe this pregnancy brought up a triggering experience from my past, or something that's going on in my relationship,
The
or
body
this
keeps the
racial
score.
Exactly.
stress
Everybody
that
keeps
I'm
the score.
experiencing at work, being a working mom, and the fact that I had to come back to work, in 3 weeks or whatever it was. Because, and let's not talk about, you had a NICU baby, so your time started then. So you didn't get time when the baby came home. So it's like, it's just a lot of things that I think kind of also, when we think about core maternal health, we don't think about like these reverberations and how they're really affecting day to day, like 2 years later, we're still having issues related to our maternal health experience. And I think that if social workers were leading or had more of a prominent role in this space, we would include these conversations and include services and supports and include people with lived experience, so we can get their hindsight and input and feedback, so that we can create things that actually are not just well intentioned but well informed.
Yes.
Yes. Yes.
And I think I'm going to date myself, but back in the 90s, we had this big push. Oh, everybody sit down and talk about your family medical history. Let's learn our family medical history. And somewhere along the line, we stopped doing that. But yet, there's this renewed focus on intergenerational trauma and the impacts of that trauma on the body, stressors, and over the cycle of our lifetime. And I think we need to encourage people again to go back to learning your family history, having open and frank conversations about not just your medical, but your mental. It's not just funny that cousin Louis was crazy. No, what really did he have? Did he have mental health issues? It's not okay that mama had a heart condition. What kind of heart condition did mama have? And we need to really be open and frank about this and not stigmatize ourselves from
Mhm.
being able to be vulnerable about these things. It's okay. You thought Auntie was crazy, but she had a thyroid condition that was untreated.
Yeah.
So we need to get back into talking about our family, not just medical, but mental health or social economic history. Like, if we talk about generations on food stamps. How does that affect each of those generations living in the projects, living on food stamps, on welfare? So we need to have these open and frank conversations so we know what could be a potential red flag when we go into the doctor, or when, cousins laying in the bed for a whole week and not getting up. And you just saying, oh, she just needs some time. No, she needs an intervention from somebody to help her.
Yeah.
So I think that's an essential part of us gaining our power back, is knowing what our history is and what has already happened in the generations before us.
Yeah.
I
So,
mean, and I have two things. Like, I guess it's just call to action time, right?
yeah,
And
that's
call to
exactly what it is.
action for social workers, I created this thing called Act C3, right? In order for you to get involved in this movement, when we talk about not just maternal mental health, but reproductive health care, advocacy work, all of it, right? The first thing you got to do is advocate. But in
Mhm.
order to advocate, we got to hit some things first. That's where the C3 comes in. We need you to be curious. We need you to be competent, because that curiosity and that competence is going to combine to make you a change agent. And
Mhm.
then the moment you achieve that level, train.
Yeah.
right?
Yep.
Train within your profession and train outside of your profession.
That
If there's
part.
any, you know what I'm saying? If there's any medical professionals on this, feel free to invite us to
Yep.
share our personal stories
Yep.
or what we know about these issues,
Mm-hmm.
right? Allow us to support with lifelong learning,
Yeah.
right? Because it's one of our things. We're committed to it over here.
Yep.
So we can provide support. Consider continuing education, inviting us out to tell our stories, to connect you with clients that may have something to teach, or even to support with ethics building, right? These
Mm-hmm.
different learning about cultural implications. Because when we talk about different communities, even within maternal mental health, there are some cultural implications, right?
Yeah.
Act C3. Consider,
Yeah.
just consider Act C3.
Mm-hmm. I
Yes.
love that.
Yes.
Mm-hmm.
So I'm acknowledging what time it is. And so what I want us to do as a wrap up, and Olympia, you just really hit it on the head by saying a call to action. I want each of us to state a brief call to action for social workers and just maternal health communities. I would just say, folks, can we do a call to action for folks in order to save the lives of Black birthing persons? So who would like to start to wrap us up?
I will just say for social workers, especially for birthing people, keep beating the drum. Like I think just consistency. Like we're screaming. Like I think we need to do all the things because we're in the middle of a crisis. Like we are fighting for our lives. So we do need to be radical. But at the same time, I think recognizing our own mental health, our own well-being, it's important to just keep beating the drum, right? Like, and I think the consistency helps us to change systems, to help people, to journey along with people, to advocate for people. And I would say with that, also don't be a gatekeeper. I was at a training and I love the way this woman reframed it and talked about being a power broker. I mean, it's a little semantics,
Like
but like I
I
think a lot of healthcare is embedded in gatekeeping, right? Like
mm-hmm.
I mean, even down to, and this is like on a tangent, and I'm so proud I haven't gone on too many. But like I was talking to someone, and we didn't know you could get a free YMCA membership if you were receiving Medicaid, NC Medicaid. Yeah, I mean, who knew? And so, but this was from a conversation of if you're getting Medicaid, does that automatically make you qualify for WIC? And then this was through a conversation with someone else who was like, yeah, and you get the free membership to the Y. And when we talk about like social determinants of health and well-being, it's like, why the caseworker didn't tell us that? I mean, it's not this person's fault, but I'm saying systems can empower people, right? Like there's always a need for more robust resources and things like that. But sometimes people just don't know about what's already out there and available. So I think that all of us cannot be gatekeepers. And if you have lived the experience, I'm not asking you to share your trauma, but to what we talked about earlier, there is power when we share our story. So in the ways that you feel comfortable, in the ways that you are inspired. I mean, it can be on your social media. It can be with an organization. I see somebody. Oh yeah, you asking about the Medicaid. Don't get me talking because you can also use your FSA for your weave if you got hair loss. But I'm saying I don't gatekeep. I'm saying like the goal is to not gatekeep and at your level of comfort share, like we have to
Yes.
share what we know, share our resources, we're sharing each other. We met virtually and now we hope girls for life, but I'm just saying like we're sharing our experiences, both lived and professional, and we're connecting with other people we don't know who will go and take from this, whatever they take and utilize it. And I think like that's the ripple effect.
Mm-hmm. Yeah. Yeah. Rochelle, you have any parting thoughts? Call to action?
I really would like to advocate for all minority women. When you go in for your prenatal appointments, whether you're high risk, at risk, or not, let them know if you need a social worker. Let them know if you need a doula. Let them know if you need a therapist. Because in those brief assessment forms that they ask you, they might not get to everything that we can get to when we do the assessment. So I believe that a care team is more effective at treating a whole person versus individual people communicating through referrals. So, it's a standard in most perinatal clinics, but we need to advocate for it being a standard in all maternity settings.
Yes, yes. Olympia, you have any other thoughts you wanted to share right before we leave?
Act C3, and for those of you who have lived experiences, remember, even though it may be hard to see, especially if you're in the storm, your pain has purpose. Don't allow that pain to sit without moving towards the purpose.
Yes, yes. And my last thought, come with creativity. I think there's so much room for creativity. And some of it isn't even all that difficult. Thinking about who's on your team to meet with patients. Do you have a social worker? If you are not a social worker yourself, advocate for social workers to be a part of the team too. This is not something that we are hoping to do on our own, because we understand that there are all types of systems, and that's one thing. We don't have one specific home where we sit as social workers. We are everywhere. Anytime there are people, we're going to be there. And so if you see a need as a professional, if you see that there is an unmet need among the people you serve, ask for us. Call us to the table. We gonna bring our chair, but you also need to make room for us, okay? So scoot over a little bit, let us pull in, and let us help you with doing this hard work, because the goal at the end of the day is the same: save lives and make it so that families can stay intact, that we are helping people to have the best birth journey that they can possibly have. If we all have that same goal, then it doesn't matter who gets to say that they did it.
Right.
We all are doing it. We all have an obligation to do it. And so that's my call, is to call us. All right. So I want to thank everybody for attending. We have a lot of comments, so I hope that all of the folks here, my wonderful what should I call this? Streaming. The posse. I like that. So I hope that you all have a chance to read the comments, because we got a lot of great feedback. Hey, maybe we'll do this again sometime. But thank y'all so much. I hope you all have an amazing night. And make sure you're pulling up your chair next time. All right, take care, everybody. Have a good night.
Bye, y'all.